We left off last time talking about this slide here, the patterns of pulmonary disease. And we're going to spend the rest of today probably talking about these patterns. So you're going to learn real quickly, there's about 4 or 5 different patterns of pulmonary disease. And we have to recognize what pattern it is that you see in the radiographs on the lung. And then we have to worry about not only what pattern it is, but where in the lung it's located at. So the type of pattern and its distribution. And if you put both of those together, right now, of course, it makes no sense to you, but after this lecture, it will make a lot more sense. And so if you could put in the type of pattern and its distribution, it can really help you diagnose what's going on in the lungs on radiographs in both dogs and cats. So that's what we're going to talk about going forward. We just left off last time talking about how normal lungs appear, how the peripheral pulmonary vessels appear, how to recognize the arteries and veins and the bronchi and stuff like that. So keep some of that in mind as we move forward through these pulmonary patterns. Okay, here's the different types of pulmonary patterns that you need to worry about, that we're going to talk about. And this can become very confusing. You would think that overall, just intuitively, you'd think the thoracic region is much easier radiographically to evaluate, because basically there's only 2 things in the thorax, the heart, the lungs, as opposed to the abdomen, of which there's all kinds of stuff going on inside the abdomen. But a lot of times I think that reading thoracic films is actually more challenging than reading abdominal films. We'll see what you think after we get through talking about the thorax and the lungs and then the abdomen. So the first thing that we're going to do is, this is because it can be very complicated and people have a hard time, even a lot of referring veterinarians have a hard time learning bronchial patterns, alveolar patterns, vascular patterns, interstitial patterns, what constitutes what. It can be very confusing. And so this is Brian Poteet's. We're going to make this as easy as possible kind of lecture and clinically applicable. So when you get out, you'll be able to use this from day one and diagnose things on radiographs. That's the goal. So I'm not a believer at all in making things more complicated than it needs to be. I don't need to say fancy words and things to try to impress you guys. So we're just going to try to teach something that's very, very basic and very clinically applicable. So having said that, there's essentially 4 kinds of patterns that you're going to see in the lungs. There's what's called the bronchial pattern, the alveolar pattern, the vascular pattern, and an interstitial pattern. Now, the interstitial pattern is the little more complicated one, because there's 2 subdivisions of the interstitial pattern. There is a structured interstitial pattern and a non-structured interstitial pattern. So depending on how you want to look at it, there's either 4 or 5, if you count the subdivisions, patterns that we need to worry about. So let's go through these one at a time, and we're going to talk about these different patterns. Once you describe what kind of pattern it is, again, we have to worry about the distribution of the patterns. So is the pattern we're describing, is it all over the entire lung? Is every lung lobe affected? And if so, are they affected exactly the same way? Or is it focal or regional? So does the bronchial pattern only affect one part of a lung lobe, or just one entire lung lobe, which would mean it's lobar? Okay. We also have to worry about, so is it symmetric or is it asymmetric? Is it, if it affects the caudodorsal lung fields, does it happen on both sides? And if it happens on both the right and left sides, does it appear basically the same on both sides? So symmetric or asymmetric distribution of these patterns. So that's what we're going to have to talk about when we talk about the distribution. So first off, let's talk about the first pattern. This one's pretty easy, is the bronchial pattern. And the bronchial pattern is the underlying pathology that will cause a bronchial pattern on radiographs, or something that affects the bronchi. So you get infiltration of the bronchi, which you remember they're the small airways inside the lung. And so we get infiltration of inflammatory cells, edema, or possibly neoplastic cells. And sometimes the bronchial walls will actually undergo mineralization, and you can see them more obviously. So what do we look for? The Röntgen signs. And the Röntgen signs refers back to the guy who discovered X-rays, Röntgen. And so that's what we describe radiographically is the Röntgen signs. So the Röntgen signs of a bronchial pattern is where we see end-on thick-walled bronchi, even in the periphery of the lung. Now keep in mind, and I'll show you some pictures here in a minute, keep in mind that if you look right where the trachea bifurcates, so in that perihilar region of the tracheal bifurcation, normally you're going to see big big bronchi there. But that's because they're large in diameter. That's the initial bronchial branching from the tracheobronchial region. And so it's normal and very typical to see big, thick-walled end-on bronchi in the perihilar region. So basically, when you're looking for a bronchial pattern, you kind of ignore that area right at the tracheal bifurcation at the carina. And you want to see, for a bronchial pattern, end-on thick-walled bronchi in the periphery of the lung, not right in the peribronchial region, okay? So what do we look for a bronchial pattern? Is the big thing that everybody will talk about is donuts. We want to look for donuts in the lung, which sounds a little odd, but that's what we want to look for. So we look for thick-walled end-on bronchi that look like miniature donuts in the periphery of the lung. That's the key, the periphery of the lung, not in the tracheobronchial region. If you have those thick-walled bronchi that looks like donuts, they're end-on, coming right out at you from the film. Okay. If you turn those bronchi now this way, it's going to look like little train tracks or little parallel tram lines, if you will. That is the same thing as the donuts, but now you're seeing in longitudinal instead of end on. So here's our cartoon that we showed from last time of normal lung. And just to remind everybody, here's our lung lobe in here. Here's the initial bronchi. So these tram lines, and this is right in the tracheobronchial region. And again, in that area that's coming out from the tracheobronchial region, that in the bifurcation of the trachea, it's normal to see thick-walled bronchi because they're large in diameter. You shouldn't see them out here in the periphery of the lung. Okay, so this white area in here, this is the branching of the airways and the vasculature inside the lung. So this is a normal lung. If you have the same ones with bronchi, now we have big, thick-walled bronchi because of dilated bronchi and airways in the periphery of the lung. So we start to see end-on donuts in the periphery of the lung, and leading up to those donuts, you'll see these little tram lines if you happen to see them in longitudinal section in the plane of the film. Okay, so what do we see with the bronchial pattern is we see thick-walled bronchi or donuts in the periphery of the lung. If we see them up here in the perihilar region, that's normal, so that doesn't count. Okay, so if you look real closely, and we'll blow this up here in a minute, here's our heart. And if you look real close, and you have to look close, there's going to be little thick-walled bronchi, little donuts at several areas. Here's a good one right in here. Several areas right in the lung. Okay, that's what we want to look for. So again, you can see here's a donut here. Here's a little donut here. Here's a good donut right in here. Here's another big donut, not a big one, but here's a little donut right in here. And so we want to see these little donuts, and we want to see them in the periphery of the lung. In this area, the tracheobronchial region, right in this perihilar region, normally we see big thick-walled bronchi, that one right there. Okay, so we kind of put a circle around this area. We ignore that when we're looking for bronchial patterns. But what we want to see is bronchi that are thick-walled, like a little donut in the periphery of the lung, like some of these are. That's pretty mild if you keep going in the severity. So now they're a little more obvious in this dog, different dogs, donut here, donut here, donut here, donut here, donut here. So it looks like a Dunkin' Donuts in the periphery of this dog's lung. Does everybody see these kind of thick-walled bronchi? Okay, so that's a bronchial pattern, which makes sense, okay? The most common cause of bronchial patterns in cats, it's super common. This is, again, very mild, but there's a little donut right here. See that in the lung? Here's another donut right in here. Here's another donut right in here. And of course, like everything that you see on radiographs, you want to put this into the clinical context of what's the cat's doing. If this cat's completely normal, that may be an incidental finding. But most of these cats that have feline asthma, they're going to be wheezing, they're going to be coughing, they have increased lung sounds when you listen to their lungs with the stethoscope. So again, you always put the radiographs in clinical context with the dog. I think one of my mentors told me long time ago, you always treat the dog and not the radiographs. Okay, so everything you see radiographically, put it in the clinical context with what the dog's doing and try to make that, fit the history, fit the signalment, all that kind of stuff to make a radiographic diagnosis. So again, here's thick-walled bronchi. This is pretty mild feline asthma, okay? This one's a little more severe. And so if I blow these up, can everybody see there's look at there, donut here, a donut here, donut here, donut here. Now what this should tell you when you're looking at this, when you're looking for these cats, especially since they're small anyway, for thick-walled bronchi, is you can't have lungs that are overexposed. You have to have good quality films where you can actually see the lung. So many times during the day when I'm reading films, the lungs, the film quality is poor, and it comes in and the lungs, half the lungs are so black, even I can't adjust them, even if they're digital on this end, enough to see this. And so we have to, again, radiographic quality, positioning is super important, and good exposure is super important. We can't make a diagnosis on something we can't see. And so if I had this radiograph and the lung fields were black because there was too much technique used, the machine wasn't set up right, and they come in black, there's no way I can see that. So we would miss a diagnosis. So we have to make sure that we have well exposed, good positioned lungs. What about this cat here? His lungs don't look normal. Obviously, they're really busy all over. It's a diffuse pattern. So every lung lobe looks like it's affected. And again, if we look in the periphery of the lung, there's a little tram line right there. That's a good example of a tram line. But again, there's a donut. Here's a donut over here. Okay. There's donuts everywhere if you look really close inside that lung. Look at all these donuts. Okay. It's a big donut right there. Okay. Big donuts that you can see everywhere. Here's that tram line that we saw right in there. So everybody cool with how to recognize a bronchial pattern. It's named appropriately, should stick with you. Okay, so in review, for bronchial patterns, we look for thick-walled, here's a severe cat with feline asthma, okay? We look for thick-walled end-on bronchi in the periphery of the lung. The most common cause of a bronchial pattern is going to be allergic lung disease or parasitic lung disease. And usually the parasitic lung disease causes an allergic response, and that's why we see that. So we see thick-walled bronchi with a bronchial pattern in the periphery of the lung, and it's almost always caused by allergic lung disease or parasitic disease. So what's some parasitic disease that can happen in the lung? Paragonymous, lung flukes, some of the other weird parasitic diseases that can happen in the lung, Strongylosis, things like that. The other thing is heartworm disease. Heartworm disease in dogs and cats can cause an allergic pneumonitis, which shows up as a bronchial pattern in the lung, all right? So that's bronchial patterns. The next pattern we have to worry about is called an alveolar pattern. So what causes an alveolar pattern? Usually it's the infiltration of the lung itself with soft tissue opaque material. So basically we take the air out of the lung and replace the air in the lung with something like blood, pus, or water or edema, to the point where it saturates and fills the entire alveoli. So pulmonary atelectasis with loss of air can also show this, but that's due to, we don't have any fluid replacement where the air goes. It's just we've lost the air inside of a piece of lung. That's called atelectasis. And I'll show you an example of that coming up. So what it causes an alveolar pattern, usually it's due to typically some type of abnormal fluid that has replaced a normal air-filled lung. So it can be blood, pus, or water. So what are the Röntgen signs? Let's go to our cartoon again. The Röntgen signs, here's our normal lung. And again, the lungs filled normally is the black area. So it's radiolucent around in here. So if I have air, if I take out the air and replace the air inside this normal lung with fluid, that's what I get. So now I have, instead of a black radiolucent air in the lung, now I have a bunch of fluid where the air used to be inside the lung lobe. And so what are these black areas in here? It looks like a tree branching. Okay, well, this is the bronchi that's still filled with gas. So the bronchi leading out to the lungs, now you see them because you're actually seeing gas inside the bronchi as they branch. So here's an example of alveolar infiltrates in the lung. So here's our heart sitting right in here. And you can see there's a bronchi that's air-filled coming out in here to supply this cranial lung lobe. Here's another air-filled bronchi that's going here to supply this right middle lung lobe, okay? And we can see a few little air-filled bronchi out in this, but here, look at this right in here, and this is the key. These are called air bronchograms. And this is, you see these because the surrounding lung now does not have gas in it or air in it, it has fluid in it. So now if I remember back from our previous lecture, we talked a lot about this bronchus coming out in here. So the bronchus, here's the trachea, the bronchus branches off the trachea and comes out to supply air to this lung lobe. And we know from our previous lecture that anatomy-wise, what structure lives just dorsal to that bronchus. Now, if you remember from our lecture, we know that the pulmonary artery lives right dorsal to the bronchus. And we know from our previous lecture that just ventral to the bronchus is going to be the pulmonary vein. So it goes again, artery, bronchus, vein on a lateral view from dorsal to ventral. So here's our bronchus, and we know the artery is sitting up in here. But the key is to an air bronchogram, the anatomy hasn't changed. We have an air-filled bronchus. Above it, we have the artery, and I can see the inside margin of where that artery sits right next to the air-filled bronchus. So I have a fluid air interface, and that allows me to see that border or that margin. But contrary to what we saw with normal anatomy, the dorsal aspect, the outside margin of that artery now, we can't see. We know it's there, but we can't see the outside margin of where the artery starts and stops. And the reason being is that artery is full of what? Fluid. Now, on the other side of it, what is the lung filled of? Fluid. And so the fluid and the fluid next to each other, they silhouette together to where you can't see the margin. And so an air bronchogram is the presence of gas within a normal bronchus, but it's surrounded by fluid-filled lung. And that means that we can still see the inside margin of where the artery or the vein sits next to the bronchus, but we can't see, the key is we can't see the outside margin of the artery or the vein, like in a normal animal we can. That's an air bronchogram. And the presence of air bronchograms equals an alveolar pattern. So typically these animals that have this, and I'm getting a little bit ahead of myself, but the animals that have alveolar patterns, for the most part, they're going to have pneumonia or pulmonary edema. This cat has pneumonia. And so all of the lungs surrounding these normal air-filled bronchi are full of pus. That's an infection of the lung or pneumonia. If this condition would go on long enough and it's untreated with antibiotics or appropriate antibiotics, then the next air opacity space that the pus can fill would be the bronchus itself. And then we get a complete whiteout or consolidation of the lung. We don't even see our bronchograms anymore because now the bronchus is also filled with pus. So here's just a close-up, and we can see, here's our bronchus. We can see the little secondary branches that are coming off the bronchus right in here. You can see them kind of branching off the bronchus. But again, the key to an alveolar pattern or an air bronchogram is I can see the inside margin of the artery bronchial interface, but I don't see the outside margin of that vessel. So there's what we said. The key, you don't see the outside margin of the pulmonary vessels due to silhouetting with fluid in the lung tissue with the vessel itself. The inside margin you still see because you still have a fluid air interface, not a fluid interface. So here's an example of here's our dog with another dog with air bronchograms. So here's our bronchus coming in, it's air filled. You can see these little branchings coming out. But again, I don't see the outside margin of the vessels like I do here. Here's a normal dog. Here's the bronchus, here's the artery, and I can see the inside margin of that artery. But in the normal dog, I can also see the outside margin of the artery. Air bronchograms, I only see the inside. Okay, that's the key. So don't confuse, and I see this quite often from referring veterinarians. They'll see this, and half the time, unfortunately, it's because they finally have a film that's really properly exposed, and they see this, and they see a bronchus coming out to the periphery of the lung, and they go, oh my God, he's got an air bronchogram. He's got alveolar disease. And that's not true. Okay, that's normal anatomy. The key to air bronchograms, again, just to hammer it home, is you don't see the outside margin of the vessel like you do here, where you see the outside margin of the vessel. So don't confuse normal artery bronchus vein from an air bronchogram. Okay. The other thing to keep in mind is one of the #1 rules with radiology is always get 2 views. You can't just get 1 view. You can do it, but if you do it, you're going to miss a lot of things. You're going to make a lot of incorrect diagnosis. Okay, here's a lateral view, a right lateral view of a dog. Here's his heart. Okay, here's a bunch of lung over here. Lung doesn't look too bad. It's got some branching pulmonary vessels. Everything looks good. What is this radiopaque thing, this line coming right in here? And for those of you who don't know, that's a jugular catheter. So that's a catheter been put down the jugular vein, and usually you want to have it terminate right before the right atrium. So somewhere in this area, it might be in a little bit too far. So somewhere up in here. Okay, they make most of these catheters where they on purpose, they are already opaque, so you can take an x-ray of it and you can see where it is. Okay, so here's our radiopaque catheter, jugular catheter sitting in here. So based on just this one right lateral view, his lungs look pretty good. On the other hand, what's rule number one with radiology? Rule number one is always get 2 views. You have to get at least 2 views, or what they call orthogonal views, so at 90 degrees opposed to each other. So here is the same dog on a VD view. So the dog looked pretty damn normal on the lateral view, but the VD view looks anything but normal. So now if I'm looking in this area of the right middle lung lobe, I have this area of white lung. Normally it should be black like over here. And if you look inside of here, I have an air bronchogram that's forming inside of that area. Well, what lung lobe lives right there on the right side? This is the right cranial lung lobe. This is the right caudal lung lobe. So that must be the right middle lung lobe. Okay, the right middle lung lobe in a dog is by far the most common area to get aspiration pneumonia. And the reason being is if you go back to this view here, think what aspiration pneumonia is. That means when you inhale through your trachea, vomitus or some kind of fluid or something that comes down the trachea, and the dog's walking on all fours. And where's this going to go? It's going to tend to come right down the trachea and go whoop, right down in here just due to gravity. So the most common lung lobe to get aspiration pneumonia is right there, the right middle lung lobe. So why don't we see it in this view? And that's because the heart's on top of it. The heart's made out of fluid, and right underneath it is our diseased lung in the right middle lung lobe. And we don't see it because the heart's in the way on this lateral view. Now, the other thing to keep in mind when you're looking at radiographs of lungs, and this is a little bit of a weird concept, so everybody listen, okay? On the lateral views, typically you will see the up lung best. That's because the up lung is the one that's most air filled, okay? So in a dog with that's a right lateral view of the thorax, that means the dog's lying on his right side. So all of his right lung lobes are down against the table, okay? The up lung is the one you see best on lateral views. So typically on a right lateral view of the thorax, we will see the left lung lobes better. So, and then we just said that the most common spot for alveolar infiltrate to go from aspiration pneumonia is right middle lung lobe. So what view do you think would be best on a lateral view, the right lateral or the left lateral view, to see abnormalities in the right middle lung lobe?
Left.
Yeah, it would be a left lateral view. So it's the opposite of kind of what you would think. So you see, just keep in mind that you, on a lateral views, you see the up lung best. Typically that's what you see. And so if I have, bottom line, this is where you have to be on your feet and you have to think, you know, when you're out on your own and you're in practice and stuff like that. So you have a dog, let's imagine you have a dog that comes in and he's 9 years old. So he's older, and he comes in and he's coughing, he's hacking up, you know, it sounds like he's hacking up a lung and he's coughing. And then the owner says, "Oh, doc, and by the way, you know, he's been vomiting lately too. I don't really know what the deal is, but he's been vomiting." And then quickly in your mind, behind the scenes, you're thinking, "Oh, old dog vomiting. Maybe it's not really vomiting. Maybe he's really regurgitating. And now he's coughing and he's got a fever." And so you're thinking, maybe this dog aspirated something. Maybe he's got megaesophagus and he's regurgitating or vomiting, or he aspirated something. And then you have to tell Sally, your technician, who's really good at shooting radiographs, you have to say, "Sally, in this particular case, because of my clinical suspicion that this dog has aspiration pneumonia, and knowing the most common spot for aspiration pneumonia is going to be the right middle lung lobe, you tell Sally specifically, I want you to get a VD view," which is what this is, "and then I want you to get a left lateral view, not a right lateral view." And again, you're trying to get the most bang for the buck on these radiographs. And we know that if the dog has aspiration pneumonia, most of the time it's going to be in the right middle lung lobe. And because of that, a left lateral view is going to show it up better than a right lateral view. Okay, so you kind of have to think on your feet as you're going. Okay, so now we defined what an alveolar pattern is. An alveolar pattern is the presence of air bronchograms or complete whiteout of lung. Then we have to define where it is. Well, we started touching base on that just a second ago. So if it's cranial ventral located in the lung, so in other words, if it is located somewhere in the ventral aspect, especially in this area right in here, typically it's going to be pneumonia, and most common due to aspiration. Now that I said also that right middle lung lobe is the most common spot for aspiration pneumonia. The second most common spots are the left cranial lung lobe and the right cranial lung lobe. So basically anywhere in the cranial ventral thorax, if you see air bronchograms, that's typical for pneumonia, aspiration pneumonia, very likely. Okay. On the other hand, if you see air bronchograms or an alveolar pattern in the caudal dorsal lung fields, that's usually not due to pneumonia. That's usually due to pulmonary edema. That is a very good general rule that for the most part will hold true. So and that's just what we said right here. So if it's cranial ventral, think pneumonia. Right middle lung lobe is most common. Okay. If the alveolar pattern is caudal dorsal or in the perihilar region, so right around the tracheal bifurcation, then most of the time it's going to be some type of edema. Okay. If the left atrium is also big, now remember we talked about last time in the cardiac lectures, where does the left atrium live? It causes a big bulge in dogs right here. And so if the left atrium's big and you have alveolar infiltrates coming from this perihilar region that goes out and radiates into the caudal dorsal lung fields, most of the time that's going to be cardiogenic edema. So he's getting pulmonary edema due to heart failure. So the first thing you want to do is if you see alveolar infiltrates in the caudal dorsal lung fields is look at the heart. If the left atrium's big, that's usually due to cardiogenic edema. Okay. If the left atrium's not big and you see alveolar infiltrates back in here, that can be due to some other stuff. Basically, it's due to non-cardiogenic edema. And there's a weird one coming up that we're going to talk about that can cause that. Okay, so distribution of alveolar patterns. Cranial ventral, you typically think pneumonia. If it's caudal dorsal and perihilar and the left atrium's big, it's usually cardiogenic edema. If there is a normal heart, left atrium is not big, and you have caudal dorsal alveolar infiltrates, it's this other thing that's called neurogenic edema a lot of times, which is non-cardiogenic edema. So neurogenic edema is edema that forms in the lung, not due to something wrong in the heart, but neurogenic edema can happen associated with trauma. If the dog has recent seizure activity, violent vomiting, they can get edema that forms in the caudal dorsal lung fields just due to these things. Very commonly, this will be, you'll see these dogs that dogs and cats that come in, they've been hit by a car and they might have neurogenic edema in the caudal dorsal lung fields. I had a cat one time that came in and it had tried to get under the garage door of this people's house while it was shutting and got stuck right at around the neck or the head as he's trying to get under the garage door. Is kind of, you know, so this animal came in with neurogenic edema. So basically alveolar pattern, cranial ventral, it's pneumonia for the most part. Caudal dorsal, and if the left atrium is big, it's cardiogenic. Caudal dorsal, if the left atrium is not big, is typically going to be non-cardiogenic or neurogenic edema. Okay. Now the weird exception for this, for cardiogenic edema, that holds true in all animals with the exception of cats and Dobermans. Why? That's a noble question. And you will ask that when you get to heaven. Okay. But cats and Dobermans have the right, you can understand it with cats, but Dobermans, I don't know. Cats and Dobermans have the right to put their cardiogenic edema anywhere they damn well please. So it can be, cardiogenic edema can be ventral, dorsal, anywhere they want in a cat and a Doberman. Okay. Again, alveolar patterns, we said an air bronchogram is an alveolar pattern. If the disease becomes so severe though, and is not treated properly, then the next airspace that will fill up with blood or pus is going to be the bronchus. And then you get a complete consolidation of lung. So what is an alveolar pattern? It's the presence of air bronchograms or complete consolidation of lung. Okay, so let's review. Okay, so the first pattern that we talked about is a bronchial pattern. A bronchial pattern is recognized by tram lines or donuts in the periphery of the lung, not in the perihilar region. Typically, bronchial patterns are caused by allergic lung disease, parasitic lung disease causing an allergic response, feline asthma, inhalation of irritants like chronic secondhand smoke and things like that will cause bronchial patterns. Okay. The next pattern that we talked about is an alveolar pattern. An alveolar pattern is that by definition, it's the presence of air bronchograms or complete whiteout of lung. Typically, the distribution, if it's cranioventrally located, it's pneumonia, likely due to aspiration. If it's caudal dorsally located, it's either going to be cardiogenic edema or non-cardiogenic edema, which is also called neurogenic edema. And the differentiator there is the left atrium big. If the left atrium is big, that means usually they have underlying heart disease, and then it's going to be cardiogenic edema. And it will be caudal dorsally located unless you're a cat or a Doberman, and then it can be anywhere. Okay, so that's the review of those two patterns. Now let's go to the next pattern, pattern number 3. This is the vascular pattern. And the vascular pattern is, again, just what it says. It's something abnormal with the pulmonary arteries or veins or both. So an alteration in size or structure of the pulmonary vessels. So the vessels are too big, they're too small, or they're abnormal in their course. So they're tortuous or pruned or blunted, something like that. So what are some structures or what are some abnormalities? Well, the big thing in animals that's going to cause a vascular pattern is heartworm disease. There's really not much else that causes a vascular pattern where the pulmonary vessels become too large and dilated and tortuous. So here is an animal here. You can see there's his heart. And we can see, we said that the arteries and bronchus and veins. So here's an artery, here's the bronchus, and here's the vein underneath it. But in this particular case, this artery right up in here looks like it may be a little bit larger in diameter than the vein. We know they should be the same size. Also, if it comes out, typically when these vessels come out from the tracheobronchial region and go out to the periphery of the lung, they should have a nice straight course. They should go straight out. They shouldn't do this. They shouldn't wind around. That's called tortuosity. Okay. In this particular case, in the caudal dorsal lung, we can see this whole thing, this huge dilated vessel right here is a pulmonary artery. It doesn't taper as it gets to the periphery of the lung. It stays really big the whole time. In fact, it may be larger in diameter here than it is up here. Okay. So a vascular pattern due to heartworm disease is we get really big, dilated, tortuous, and pruned pulmonary arteries. So by pruning, look at this vessel, it kind of comes out in here and then it just stops. Okay, so it's pruned off. So dilated, tortuous, and pruned pulmonary arteries is typically what you see with heartworm disease. Here's another dog with heartworm disease. So look at this vessel right in here. So it's coming out in here and it just stops right in here. Here's another pulmonary artery coming out in here. This one's huge. It comes out here and look at this one here. It kind of winds around. It's really dilated here compared to even right in here. And so that's typical of what you're going to see with heartworm disease, a vascular pattern where the pulmonary arteries become really big, dilated, tortuous, and pruned. Okay, here's another kitty cat here. And again, we said that in cats, typically they won't, with heartworm disease, their hearts do not become big. Okay, but in cats, what we look for is we look for a dilated pulmonary artery. This right caudal lobar pulmonary artery is huge. It's really big, it's really dilated, where it extends out here into the periphery of the lung. And this cat also has a little bit of kind of a coalescing pattern right in here. This lung here on the left caudal lung lobe doesn't look like it does over here. So you may have a little bit of allergic lung disease because there's some little bronchi in this area. So we may have allergic lung disease secondary to his heartworm disease, which is not uncommon. Big dilated pulmonary artery. Okay, so we've learned about 3 patterns, 3 lung patterns, only one more to go. So again, in review, our bronchial pattern is the presence of thick-walled bronchi or tram lines in the periphery of the lung lobe, and it's caused by allergic lung disease or parasitic lung disease. The second pattern was the alveolar pattern. An alveolar pattern is characterized by the presence of air bronchograms, true air bronchograms, or complete whiteout of lung. Typically, if it's cranioventrally located, it's due to pneumonia. If it's caudal dorsally located and the heart is big, particularly the left atrium, it's usually cardiogenic pulmonary edema. If it's caudal dorsally located and the heart is normal is typically non-cardiogenic edema or neurogenic edema. If you're a cat or a Doberman, you don't follow the rules. The third pattern that we just got through talking about is the vascular pattern. The vascular pattern, for the most part, is going to be heartworm disease. And heartworm disease causes the peripheral pulmonary arteries to become dilated, tortuous, and pruned. Okay. Now let's venture off into our fourth pattern, which is the interstitial pattern. And we just to remind you, there are two subclassifications of an interstitial pattern. There's what's called structured interstitial, and then there's non-structured interstitial. The structured interstitial pattern is the easiest probably pattern of all of them. So a structured interstitial pattern, just like the name would tell you, there's something that has structure in the lung. So basically you're looking for a mass or a defined pulmonary nodule, soft tissue nodule, usually in the lung itself. So what causes these? You can have neoplasia, especially if it's a middle-aged to older animal, that causes a mass in the lung. And neoplasia in the lung, you can either have primary or metastatic lung disease. You can also have granulomas that can form in the lung and cause a mass. And then you can also have some tricky things called pulmonary osteomas or pulmonary osseous metaplasia that can happen in the lung, and it's benign, totally benign, doesn't mean a damn thing. And you leave them alone, and we're going to review these. So anything that causes a structure or a nodule or a mass, defined mass in the lung, would fall under this structured interstitial pattern. The non-structured interstitial pattern would be everything else. So that's the best way to describe it. So you have now 5 buckets of pulmonary patterns. If you have a bronchial pattern, that's 1 bucket. If you have an alveolar pattern, that's bucket number 2. If you have a vascular pattern, that's bucket number 3. If you have a structured interstitial pattern and you have nodules or mass lesions in the lung, that's bucket number 4. If it doesn't fit in the first 4 buckets, throw it in the non-structured interstitial bucket. And we'll talk about that. Okay, so again, structured interstitial patterns, discrete nodules or mass lesions in the lung. Okay, then you have to, again, we have to describe the nodules themselves and their distribution, just like any other pattern. So if you have a mass or nodules in the lungs, the first thing you want to do is, count them. So is there one or are there multiple? Okay, if there's one and it's really big and the dog's old, there's a good chance it's going to be a primary lung tumor, like a bronchogenic carcinoma would be the most common one. If they're really small, then it could be either metastatic disease, especially if they're variously sized. So you could have metastatic lung disease that came from a primary tumor somewhere else, like in the prostate or the ovary or a kidney or whatever. Okay. Then you also want to look at the nodules themselves. Look at the edges of those nodules, the circumscribed edges of those nodules. Are they all perfectly round and well-defined? Or are the edges ill-defined? And that might be able to give you a hint on what is the etiology of those pulmonary nodules. And then you want to carefully look at the opacity of those nodules. Okay, again, there's 5 radiographic opacities that can happen on any radiograph, and that would be metal, mineral, or bone. There would be soft tissue, and then fat, and then gas. That's the only 5 that you can have. So you want to look at each one of those nodules and you want to describe, okay, are these nodules, are they soft tissue or are they mineral? So the characteristics of these, just by their description, will give you a little bit of a clue as to what they are. So let's review that. Here's our normal lung. Here's a structured interstitial pattern. Now we have nodules in the lung. Okay, so if I'm looking at this cartoon, are those nodules, are they all well-defined? Yeah, they look like they're all well-defined. The edges of them would pass the Sharpie test. Are they all the same size? No, they're all different sizes. So now we have well-defined, variously sized nodules within the lung, which would go with a structured interstitial pattern. Okay. So here's a real case example. So if I'm looking at this dog's lung, it looks to me like he's got a big nodule up here. He's got another nodule that's sitting on top of it here. He's got probably another one sitting on top of it here. He's got one here. He's got a great big old nodule here. He's got another nodule here, and probably 2 sitting right next to each other right in here. So he's got several. So he's got maybe one here. He's got multiple, there's another one here, multiple nodules throughout the lung. So we know damn well that it's a structured interstitial pattern. And then you have to describe, are these nodules, do they look like they're well defined? I think so. I think they're pretty well defined. Are they all the same size, or are they variously sized? Well, obviously they're variously sized. So now we have a structured interstitial pattern with multiple, not just one, multiple well-defined, variously sized soft tissue. They're soft tissue opaque, they're not bony opaque, nodules throughout the lung. Okay. Most likely, especially if this dog is middle-aged to older, this is going to be some type of metastatic lung disease. So he's probably got a primary tumor somewhere else that has metastasized to the lung. And anytime you see these, for the most part, 99% of the time, if you see multiple variously sized, rounded soft tissue nodules scattered throughout the lung, that prognosis for that animal is going to be really poor. So again, now this is another dog. He's got multiple structured interstitial patterns. So he's got multiple nodules all over the lung. They're variously sized. There's some sitting superimposed over the liver. Okay, here's some here, here's some here. They're all soft tissue opaque. This time, I think they're a little poorly defined compared to the last ones. The edges of them are not quite as well defined. That one's still pretty well defined, but some of them aren't. Okay. And again, are they all the same size, or are they variously sized? No, they're variously sized. Is only one lung lobe affected, or all the lung lobes affected? Looks like all the lung lobes are affected. So again, this is a structured interstitial pattern. He's got multiple variously sized, rounded soft tissue nodules with poorly defined margins scattered throughout the lung. Most likely, it's going to be some type of metastatic lung disease, which is a poor prognosis. So again, in veterinary medicine, it's a little bit different than in human medicine. Okay. In veterinary medicine, this dog maybe is 10 years old, and we see this, the dog's coughing, and we radiograph their lungs and we see these nodules. Okay. Then what do? You go back to the owner and you say, hey, Miss Jones, unfortunately, your dog's got all these nodules all over his lungs, which typically is going to be metastatic lung disease. So maybe he has a primary tumor somewhere else. What do you want to do? Our job as veterinarians is to give these owners viable options. It's not our job to pick the option, but we have to be honest with them, and you give them the full spectrum of options of do nothing to let's go all out, let's talk to an oncologist and blah, 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 and let the owners decide. Okay. So in some ways with this dog, if he's got metastatic lung disease already, does it really matter where the primary tumor is? It really doesn't, because the prognosis is horrible. Okay. You can't take these out surgically. They're all over the lung. Okay. A lot of times you can put them on chemo, but in reality, a lot of times the chemo doesn't do anything at all. It seems like, just like in people, you may make the dog's life kind of miserable from here on out, and the owners are going to spend thousands of dollars real quickly, and you may get an extra couple of weeks out of the dog. And even that quality of life may not be the best. Okay. So there's some owners that would elect no. On the other hand, if this was a person, obviously they're going to go for it, and they're going to do all that stuff, and they're going to try to find the primary tumor and try to take it out if they can and all that. So it's different on how these are handled in veterinary medicine versus in human medicine. Okay, what about this dog here? This dog has a structured interstitial pattern. There's a nodule here, there's a poorly defined nodule here, there's some nodules up in here. Now, we also said that in this region, remember, there's lymph nodes that live in the thorax. Just to remind you, in this area, the name of the lymph nodes that live in the tracheobronchial region are the tracheobronchial lymph nodes. There's also a set of lymph nodes that lives right in here, which is kind of bulgy and big on this film, the craniomediastinal lymph nodes. And there's lymph nodes that live right here called the sternal lymph nodes. So this dog has several things. So he's got lymphadenopathy and large lymph nodes in those three places in the thorax, but he's also got nodules in his lung. Okay. So there's a really good chance this dog has something besides, it could be neoplasia, but it also could be granulomatous disease or fungal disease. Okay. This dog here had fungal disease. He had what's called coccidiomycosis, and you probably learned about that. And this is really common in the arid desert areas of the world. So in the US, you'd think Arizona, Nevada, parts of California. Coccidiomycosis, otherwise known as valley fever, pretty much every dog has it. Okay. So what are these little opacities right in here? They're well defined. They're kind of U-shaped. Those are metallic hemoclips that they've been in surgically, and they probably biopsied one of these lymph nodes and clamped off the blood vessels with those metallic hemoclips. Okay. but he's still got a structured interstitial pattern. So nodules. So again, if you want to describe these nodules, are there one or more than one nodules? Are they in the same region? If they are only one or two and they're really big and probably in the same lung lobe, primary lung neoplasia is your best bet. And the most common primary lung cancer in a dog is a bronchogenic adenocarcinoma. If there are multiple, just like on these films we just saw, multiple variously sized nodules seen all over the lung, chances are it's metastatic lung disease and there's a primary tumor lurking somewhere else that has metastasized to the lung. If you have lymphadenopathy present also besides the nodules in the lungs, then I would consider some type of fungal disease, especially if the animal has a travel history or lives in a desert-like area. Most of the time, fungal disease is going to be in younger to middle-aged dogs. Most of the time, cancer is going to be in middle-aged to older dogs. Okay, so again, structured interstitial patterns. So here's a nodule here. Here's another nodule here. I think I have a close-up right in here. Now these nodules, here's another one here. These nodules are cavitary. So they used to be fluid-filled, but now that nodule has grown and probably grown to the point where it has communicated with a air-filled bronchus, which then allowed the fluid, probably a necrotic center in these nodules, to drain out into the airway. Okay. So bottom line is if you see cavitary nodules, they're still variously sized. In an older dog and it's thick-walled, we start thinking, again, cancer. Neoplasia would be your best bet. Sometimes these will be a granuloma or due to parasitic lung disease, but if it's an older dog, again, even if they're cavitary, put neoplasia first on your list. Okay, so we have to take a break. So we're going to take a break there. We're going to come back at 10, and we're going to talk about the rest of lung patterns and kind of finish up with that.